Bismillah ar-Rahman ar-Rahim. Our lecture today about the upper genital tract infection. First of all, Chlamydia trachomonas, most common sexual transmitted disease. It is obligatory intracellular bacterium. About 5 to 10% of women below 24 years are thought to carry infection. Serovirus of Chlamydia A to C infected of conjunctiva, D to K infected genitourinary system, and another type pneumonia respiratory system, and lymph granuloma variant called proctitis. Sign and symptom of presentation of chlamydia: asymptomatic, vaginal discharge and lower abdominal pain, postcoital intermenstrual bleeding, mucoplural and cervical discharge, dysuria. Complication in future: PID, perihepatitis, neonatal conjunctivitis, adult conjunctivitis, and Reiter syndrome reactive. Diagnosis depend either culture and ELISA test or nucleic acid amplification test, either PCR or LCR, and this depends on the sensitivity and fluids and availability in our country. And another method, Optima COM2 and BD Pro, and real-time PCR screening, for whom we done partner of patient diagnosed or suspected with infection, history of chlamydia. Last year, patient attend genitourinary medical clinic, and patient with 2 or more partner within 12 months, woman undergoing termination of pregnancy, history of other sexual transmitted disease and HIV. Treatment: general advice: avoid intercourse, condom use, retesting if any doubt about the complete treatment, test of cure. Contact tracing, follow up if change partner, retesting between 3 to 12 months. Antibiotic: the following treatments are effective for uncomplicated chlamydia infections, such as doxycycline, azithromycin, ofloxacin, erythromycin. This commonly used in chlamydia infection. Another type of upper genital tract infection is gonorrhea. Gonorrhea gram-negative diplococca and may be found in the epithelium and endocervical and urethral mucosa and oropharyngeal and rectal mucosa available. So the sample when taken from this part of the body, and the treatment depends either on the presentation of the bacteria. Chronic asymptomatic infection is uncommon. 50% of infected women are asymptomatic, 70% infected men are symptomatic, and it causes urethritis, tonsillitis, conjunctivitis, and proctitis. This is the Staphylococcus gonorrhea. Sign symptom either asymptomatic, as mentioned in previous slide, vaginal discharge, dysuria, proctitis, rectal bleeding in the cervical discharge, and pelvic redness. Diagnosis depend on gram stain, culture media, and DNA-based detection, and this was test also done for all patients fully or for sexual transmitted infection and treated with gonorrhea before sexual intercourse. So 50% of women treated with gonorrhea have concomitant chlamydia infection. So treatment should cover the both bacteria. Women should have 2 sets of culture performed following treatment tests of your treatment, screen both partner, and contact tracing, education about long-term sequelae of the disease, such as or complication, chronic pelvic pain, tubal infection, subfertility, adhesion. Antibiotic according to the sensitivity of the patient: cephalosporin, ampicillin, ceftriaxone, cefixime, and azithromycin, amoxicillin, ciprofloxacin, as the sensitivity of the test was present. Mycoplasma genital is another probable sexual transmitted infection implicated in PID, and the women who visit the non-gonococcal urethritis, and it is difficult to detect, requiring special culture media for or PCR tests. Endogenous anaerobic such as bacteroid species or Mycoplasma homini often come in secondary invader and are responsible for subsequent tubal abscess formation, tubal collection. Cervicitis is another infection that ascending infection on the sequelae of the PID, ascending PID, mucopurulent cervicitis, التهاب عنق الرحم, is a clinical diagnosis based on detection of purulent mucus on cervical os. And it is either sometimes may be confused with normal ectropion, cone benign and not infectious disease. So post-coital bleeding or combination of purulent vaginal discharge and post-coital bleeding may be lead to diagnosis. However, it can be asymptomatic. Etiology often caused by sexual transmitted infections such as non-gynecological infection, and another cause may be due to ulceration if present for herpes simplex, Bothian follicle, or mucous contents up to 1 centimeter in diameter and lead to chronic cervicitis, which cause scarring in the cervix. This is the cervix, and this healthy cervix, and inflammation if occur. This is the redness and may lead to postcoital when postcoital started. PID is a broad term used to cover infection arising from the endocervix, leading to infection upper to the uterus, tube, parametrium, and ovaries, and overlying pelvic peritone, subsequently leading to tubo-ovarian pelvic abscess. Sometimes infections separate to reach hepatic capsule, leading to perihepatitis. Chlamydia and gonococcal infection are commonly implicated, and other organisms such as bacterial vaginosis may be identified. How infection can reach the upper genital tract? By number 1, ascending from the vagina cervix through the urinary tract cavity, introduced to the upper genital tract while operating upon to its organs, such as salpingitis following sterilization of the tube. Blood-borne pulmonary TB is separated from adjacent organs such as acute appendicitis, urinary tract infection, lymphatic. PID is a polymicrobial infection. 80% of cases are triggered by sexual transmitted infection. Pathophysiology. An inflammation of the mucosal lining of fallopian tube lead to damage of the cilia, scarring in the lumen, and pocketing and partial obstruction lead to ectopic pregnancy. Another complication due to post-oxidate and in the fimbria and lead to peritoneal inflammation and scarring adhesion, and this leads also to tubal ovarian abscess formation and distortion of the anatomical and omental adhesion. Chlamydia and gonorrhea can cause perihepatitis with adhesion between liver and peritone or peritoneal cervix, and violent string appearance at laparoscopy. Fitz-Hugh Kearns syndrome will appear after laparoscopic finding. This type of adhesion picture reveal adhesion to the tube, broad ligament, and uterus, and this may be extension extra-peritoneal and outside and reach the liver and pelvic organ. Clinical features of PID: abdominal, pelvic, cervical instrument, intermenstrual bleeding, increased abnormal vaginal discharge, deep dyspnea, vaginal discharge, high-grade fever, nausea, vomiting, right upper abdominal pain, generalized peritonitis, and tubal damage. Differential diagnosis: number one, ectopic pregnancy, ovarian accident, acute appendicitis, irritable bowel syndrome, inflammatory bowel disease, urinary tract infection, bowel torsion, and psychosomatic pain. About the investigation, blood tests for complete ESR, C-reactive protein, and pregnancy test to exclude ectopic pregnancy. Microbiological tests: endocervical swab for gonorrhea, for chlamydia, microscopic for cervical calcium, and if positive, high risk of sexual transmitted infection, offer microscopic culture for transvaginalis, Trichomonas vaginalis may also excluded. Tests either by serological or high vaginal swab. Radiological investigation: transvaginal sonograph also benefit by assessing free fluid, exclude either diagnosis, affected tubal ovarian abscess or ectopic pregnancy, or Doppler MRI CT kept for cases of doubtful diagnosis. Surgical diagnosis: definitive diagnosis procedure is laparoscopy as an invasive procedure. It should be kept to cases with doubtful diagnosis or patient failure to respond to antibiotic within 48 to 72 hours. Treatment: most patients are with mild, moderate disease are treated as outpatient. Antibiotic cover chlamydia, gonorrhea, and anaerobe. So ceftriaxone, doxycycline plus metronidazole, flagyl may benefit, or ofloxacillin metronidazole may be also benefit for 5 days duration. Inpatient care indicated for tubal abscess if suspected, severe infection, generalized sepsis, poor inadequate response to oral intake treatment, severe pelvic abdominal pain requires strong analgesia, acute abdomen. And those should be treated with IV antibiotic initially, cephalosporin and metronidazole, with preparation before surgery was done. It is essential that sexual partner is screened for sexual transmitted infection and treated. Surgery is indicated to drain pelvic abscess if doubtful diagnosis, maybe ectopic, maybe early abortion, patient not response to treatment, ultrasound guided aspiration is less invasive effective as laparoscopy or laparotomy. Complication of upper genital tract infection by according to the infection: PID, sequelae of PID, either recurrent PID, ectopic pregnancy, tubal factor infertility, chronic pelvic pain. Patient counseling is screened and treated, otherwise reinfection can occur. Barrier contraception reduce risk of recurrent infection, explain possible sequelae of PID. Early effectiveness treatment reduce the risk of fertility, and early medical advice if pregnant, risk of ectopic pregnancy. As a sequelae of PID in future may lead to either ectopic, either infertility or adhesion. Female genital tract tuberculosis: exact incidence is not accurate now, under reported varies from 1 in US to 1 in 19 in various parts of India. And female genital tract TB is always secondary to pulmonary, commonest or extrapulmonary TB. So primary TB may be who are partner of the male and active genital urinary TB through infected semen. Fallopian tube involvement about 10%, and this leads to damage of the cilia and lead to a permanent blockage of the tube and infertility. Endometrial TB 50 to 80, ovarian TB is rare, and cervical also rare, and vaginal vulva. This picture reveals the TB extended in patient with current infection. TB and infertility, as mentioned, is the commonest presentation. Both the primary and secondary infertility may occur. The reason for infertility are the blocked damaged tube or non-receptive and damaged endometrium and the Asherman syndrome of the uterus and the ovarian damage. Clinical presentation: systemic manifestation, fever, lymphadenopathy, crackle on the chest exam, and abdominal examination, mass, ascites, vaginal, uterine enlargement, pyometria, adnexal tenderness, PID, and hypertrophy or ulcerative region of the cervix, vagina, and may sometimes may lead to gynecological fistula if they diagnosis. Investigation: complete blood count, ESR, chest X-ray, Mantoux tuberculin test, serological HIV, endometrium biopsy, biocurate, and aspiration in the premenopausal phase, a premenstrual phase, for the histopathological testing for granuloma, specimen for AFP, smear and culture and PCR should be done. Mycobacterium smear of Levenstein Jensen media, culture for secretion from vagina, cervix, peritoneal fluid, or tubal biopsy, BCR, and imaging method to exclude another or primary source for lung, ultrasound, CT, MRI, and another investigation will be needed to reach the diagnosis. Blood marker of genital TB different from the country to country and from patient to patient. Hysterosalpingogram is contraindication in cases of genital TB. And hysteroscope, laparoscope, macroscopically, the tubes are thick with fibrous tissue and peritubal adhesion, but and inflammation, and tubal are patent but functioning is less, usually yellow pus with caseation, and the histopathology is most, and culture for AFP is spot diagnosis. Treatment has a medical condition, 9-month regime, rifampicin and ethambutol, pyridoxine, and 6-month regime for the rifampicin, isoniazid, and ethambutol, and another regime. In our country, very less common TB nowadays because of we have a good condition. Thank you for listening.